Non-functioning pituitary tumors. Etiology and Pathophysiology. Non-functioning pituitary tumors, chromophobe adenomas, are usually benign macroadenomas, greater than 1 cm diameter. Epidemiology. The incidence of non-functioning pituitary tumors is estimated at 5 to 10 per million per year. Clinical presentation. Local pressure effects often result in headache and visual disturbances. The patient may present with symptoms of hypopituitarism or hyperprolactinemia due to pituitary stalk compression, fatigue, lack of well-being and hypogonadism. Alternatively, it may be an incidental finding following routine eye testing or a head scan for unrelated purposes. Physical signs. It is important to check carefully for evidence of bitemporal, sometimes only upper quadrantic, hemianopia. Features of hyperprolactinemia may also be present. Investigation. A full assessment should include tests of anterior pituitary function, an MRI scan of the pituitary fossa, and formal tests of the patient's visual fields and visual acuity. NB. The serum prolactin result must be seen before surgery is considered in any patient with a suspected non-functioning tumor to exclude the possibility of a prolactinoma that would be amenable to medical therapy. Visual field defects in pituitary disease. The classical visual field abnormality in a patient with a pituitary macroadenoma causing optic chiasmal compression is a bitemporal hemianopia. However, it is important to remember that pressure on the optic chiasm from below initially results in a superior quadrantanopia, either unilateral or bilateral, before progressing to a complete bitemporal field defect. By contrast, a mass arising in the suprasellar region and primarily compressing the chiasm from above, e.g. a craniopharyngioma, is likely in the early stages to be associated with an inferior quadrantanopia. Differential diagnosis. The differential diagnosis includes other sellar or parasellar masses, including cysts, craniopharyngioma, meningioma, metastatic, infiltrative or granulomatous disease, and lymphocytic hypophysitis. Treatment. A non-functioning macroadenoma in a patient with pressure symptoms or signs, particularly loss of visual fields, requires urgent surgical debulking, transsphenoidal or occasionally transcranial hypophysectomy. Surgery may lead to partial recovery of anterior pituitary function. Postoperative radiotherapy should be considered if tumor removal is incomplete or subsequently if the tumor recurs. If there are no pressure symptoms or signs, it may be acceptable in some cases, e.g. frail elderly patients, to adopt an expectant approach. Either way, patients require serial MRI scans together with assessment of visual fields, visual acuity, and anterior pituitary function. Complications. Operative complications include transient diabetes insipidus in 10 to 20% of patients, which may persist in 2 to 5%. Pituitary radiotherapy results in some degree of hypopituitarism in about 50% of patients after 10 years. Prognosis. Hypopituitarism is associated with an increased mortality rate of at least twice that of the general population.